Hi, everyone. I'm Ashley Bassett.
And I'm Catherine Logan.
And welcome to the Sports Docs Podcast. On each episode, we chat about the most recent developments in sports medicine and dissect through all the noise so you know which literature should actually impact your practice. Today, we're coming to you live from the American Orthopedic Society for Sports Medicine annual meeting in Nashville, Tennessee.
The AOSSM annual meeting is the premier sports medicine conference each year, hosting over 3,500 attendees with hundreds of poster and paper presentations, exhibitors, and instructional course lecturers. This year proved to be as spectacular as years past. We were fortunate to have the opportunity to catch up with many of the presenters at the meeting and get their take on some of the hottest topics in sports medicine.
Over these 7 episodes, we're going to be exploring some cutting-edge sports medicine with these experts who are presenting at the AOSSM annual meeting. Are you an early career orthopedic surgeon or fellow eager to expand your expertise? JRF Ortho has some exciting news. Starting early in 2026, JRF Ortho is launching a quarterly traveling fellowship program designed to provide you with hands-on exposure to osteochondral allografts, meniscus, and ligament repair, all in a dynamic and stimulating hands-on environment.
Each fellowship will be led by distinguished faculty with opportunities to learn in different regions across the U.S. Fellows will also get an exclusive behind-the-scenes look at tissue processing with tours at our partner facilities in Denver.
Every quarter, 3 outstanding candidates will be selected for this unique experience, and one of those quarters will be dedicated entirely to an all-female cohort, with both faculty and fellows coming together to advance women in orthopedic surgery.
Applications open this September for the winter program, which kicks off in January. Keep an eye out for details and the application form at jrfortho.org and on social media later this summer. Want to learn more? Reach out to marketing@jrfortho.org. JRF Ortho, restoring movement together.
Today's episode is going to focus on the management of UCL injuries and throwing athletes. We're joined today by 2 outstanding guests.
Dr. Michael Banffy is a professor of orthopedic surgery and chief of orthopedic sports medicine at Cedars-Sinai, as well as a director of the Orthopedic Sports Medicine Fellowship at Kerlan-Jobe. He is a team physician for the Los Angeles Dodgers and the Los Angeles Rams.
Dr. Christopher Camp is an orthopedic sports medicine surgeon at the Mayo Clinic in Rochester, Minnesota. He is the sports medicine division education leader for the Department of Orthopedic Surgery at Mayo and is a team physician for the Minnesota Twins. Dr. Camp has a particular interest in elbow UCL surgery and has published extensively on this topic, so we're very excited to hear his take today. So without further ado, let's get to the exhibit hall.
All right, Mike, Chris, thank you for joining us for this special episode of the Sports Docs Podcast live at AOSSM. We're super excited you're here, so thank you for joining us.
Thanks for having us. Excited to be here.
Yeah, thank you. So today we're talking about the management of ulnar collateral ligament injuries or UCL injuries and throwing athletes. Now, before we get into treatment, it's been a minute since we did a UCL episode back with Mike Siccotti in 2021. So we should probably do an update for our listeners on, workup and management. So, Mike, how does a patient with a UCL injury typically present, and what are you looking for on exam to guide your treatment?
So it can be variable, but the typical presentation is just pain, they'll have medial elbow pain, and then you need to distinguish if this is going to be from the ligament versus from one of the flexor tendons that's on the inside of the elbow. There can be some changes in their velocity, there can be changes in their accuracy, and so when you have that whole combination, then that really keys you into the diagnosis.
Mm-hmm. Yeah, perfect. Anything to add there as
No,
far as
I think it's perfect, and that's often a lot of the challenge too, is distinguishing it from those other things on the medial elbow, making sure it's the ligament and not the flexor pronator group or the ulnar nerve.
Yeah. So, Chris, as far as imaging, we did a lot of, you can imagine, ultrasound talk with Dr. Siccotti.
Yes.
We also know that MRI is really a gold standard for diagnosis and, as far as, do your classification. So in terms of location of the tear, partial, complete, all those types of things, there's been a lot of data. How do you work through all those things? Do you go right to always ultrasound and MRI? Chris, what's your imaging sort of breakdown?
So everybody gets x-rays, and if there's a suspicion of a ligament injury, we're almost always going to get an MRI. And usually that tells us what we need to know. 90+% of the time that gives us the answer. There are some times where we have these equivocal situations where clinically there's a high index of suspicion of a UCL injury, but maybe you don't see it on the MRI. then they might benefit from some sort of stress imaging, which is usually either a stress ultrasound, or now there are certain MRI sequences. So a fever MRI, which is where the patient has their elbow in a flex position, shoulders externally rotated. You put a little weight on the forearm, so it actually puts a little valgus load on the elbow, can open it up. So it's kind of like a dynamic MRI. So in certain situations, we'll get those. But that's usually only when the standard MRI looks clean, but there's a high clinical suspicion.
Yeah, the only thing that I'd really add is really the importance of that fever view. When I trained with Lou Yoakum, everyone would get a stress X-ray. So you'd have to put these lead gloves on and stress their elbow. And I do not do that really ever anymore. Similarly with the ultrasound, in my hands, I think that the diagnostic value of that is not very useful either. And then the logistics of trying to send them to somebody to do that isn't really there. So I actually always get a fever view on a throwing elbow of a thrower, and I think that can be really useful. What I hate having happen is if they don't get that view, you're suspicious about the ligament, then you got to send them back to the MRI. So it's part of our protocol at our institution.
Yeah, and for Mike, for those who don't have that access, like, did you have to set up special protocols? Was it certain imaging centers? How easy was that to do?
So I believe it actually developed in Arizona at a company called Simon Med, and
we have that.
So they are actually national, and so I think that protocol is very easy to set up through them. And then it just really is educating your radiologist to make sure they can do it. It's not very difficult. It's not the most comfortable thing for the athletes, but I think it's worth it.
And generally, too, I think if your radiologists don't do that, the Simon Med Group and others that do are very happy to share the protocols, too. So you can always connect your radiologist with others who do it, and they can learn and adopt it.
Yeah, it's great.
So now we want to talk a little bit about treatment, and we'll start with non-surgical treatment. So we know that there are many factors that have been shown to impact success of non-surgical treatment, including the location of tear, with one showing about 82% of professional baseball players who failed non-op treatment had distal UCL tears. So Mike, what are your indications to proceed with conservative treatment, and what patient factors are you considering when making that decision?
So I think that pretty much universally, most athletes want to try conservative treatment. No one's jumping to have surgery. I think that they've had symptoms for quite a long time, and then they're seeing me for the first time. Then maybe those are the ones. But you could say those are the ones that have failed conservative care already. I think that it really depends upon the attritional status of the ligament. It's going to drive you one way or the other. That also will take a role with regard to our surgical management as well. I think that if you have a partial thickness tear, if you have somebody that is at the very end of their career, or be it professional or collegiate, and they don't really have a desire to continue being a pitcher, those are things you could utilize to decide which way you're going to go, surgical versus non-surgical.
Yeah, and anything as far as, Chris, with regard to the tear location that makes you steer one way or the other?
Yeah, absolutely. Proximal tears tend to do better with non-operative treatment than distal tears. And partial thickness tears obviously do better than complete tears. So the ideal tear for non-operative treatment is going to be a partial thickness proximal injury. The worst tear would be a complete distal tear in a pitcher. So I kind of use that as an algorithm. And to be honest with you, if it's a complete tear that's distal in a pitcher, chances of success with non-operative treatment is pretty close to zero if it's somebody who's going to be playing for a long time. So those we tend to move towards surgery pretty quickly. Everybody else, I think there's a role for non-operative treatment in.
Yeah, so specifically with non-operative treatment. So before I went to med school, I was a physical therapist for 7 years, and not uncommon to get the script that just says eval and treat. And how involved do you guys get with creating your non-op protocol? I'm sure you're a little bit more, involved with the surgical, but Mike, do you have any thoughts on the non-operative protocal?
Well, to be honest, I still use some templates. But fortunately, my templates have been developed for the throwing athlete. I think that the mechanics are critical. They got to make sure that they have good motion in their shoulder, which is going to translate to their elbow. Similarly for the kinetic chain, hip and mobility, core mobility, I think is critical as well.
Yeah. Not a form of the eval and treat.
Yes, exactly. So we mentioned rehab protocol as part of the non-operative treatment regimen, but injections have also been described, specifically PRP. So Chris, what are your thoughts on the use of PRP for the non-surgical treatment of the UCL, and how does that change the recovery for that patient?
It's a great question. Unfortunately, we don't have any clear evidence to tell us the right answer. I've been involved in a few studies on this, and almost all of them end up being equivocal. So there are some studies that say it can work, but we don't have any really good head-to-head comparison studies saying that it is better than non-operative treatment. So for me, I don't use it in most patients, but I do think there may be a role for some of those partial thickness proximal tears, particularly if you have a patient that really wants it and is really buying into it, or if they've had success with PRP elsewhere in the body, then those are the times that I really, really think about using it.
Mm-hmm.
Yeah, and some of the data actually has shown that they do worse. They're more likely to require surgery if they've had that PRP injection. So similarly, I do not use it routinely. I think that for the muscular injuries or the tendon injuries, the flexors, I think that they could have a role with that. You know, if you translate the data we have from tennis elbow on the outside of the elbow, I kind of use that for the inside of the elbow as well.
That makes sense.
Yeah, and I think I practice in Colorado. There's a lot of interest in biologics. You know, there's a lot of people, especially in that sort of Boulder community, trying everything. And, you know, it's hard because I think, you know, sometimes the data is not really matching up, but people do want to try these things and, trying to make that decision if it's appropriate for them. So as far as, you know, we know some of the UCL injuries do well non-operatively, but there's also been a real increase in UCL reconstruction or repair among athletes. Chris, what do you think is driving this trend?
So I think the injuries are up, so surgical rates are up because injuries are up. Injury rates are up really for there's three reasons that continue to drive the increase in UCL injuries. And if you look at it, I mean, there's hundreds of data points, but you can kind of bucket them into three main risk factors. One is throwing with poor mechanics. The second is throwing too much or high volume. And the third is throwing too hard or spinning the ball too hard. Those are really the three main things. For our young kids, all three of those are a problem. They usually have poor mechanics. They're also throwing too much, and they're probably throwing too hard. So you really need to work on all three of those if you can. None of them are going to stop throwing hard. So usually you can't make much progress there, but you can try to work on having them not throw too much and try to optimize their mechanics. If we go to the other end of the spectrum and look at the professional athletes, generally their mechanics are pretty sound. So you're not going to the orthopedic surgeon's not going to make major pitching changes to the MLB pitcher. So, and they're also not going to throw less either, or they're not going to throw slower. So we really have to look at the volume issue to try to do it for the professional athletes. But that's part of the challenge is that Major League Baseball season is still 162 games. Everyone has 9 innings, and so there's still a certain number of volume of innings that have to be thrown. So it is a very difficult challenge at that level. But I think those are all the reasons why we keep seeing injuries going up, because the velocities and spin rates keep going up too.
Yeah, there's such a push on velocity. You know, if you look at the amount of pitchers that throw over 100 miles an hour in the major leagues, like it's incredible. And I think that's because of the training. And I think that starts in high school. And I think there's a big emphasis on using heavy balls in their throwing program, which is just not the healthiest thing for the elbow. And that's going to lead to these injuries. And
the other concern here too is that even though we know that this is a risk factor, the players also know that it's a risk factor. They know, we've surveyed them and studied this. They know that weighted balls increase their risk of injury. They know that a higher velocity increases their risk of injury, but they don't care.
Are you talking about the youth?
Everybody. This is true of youth and professional athletes. So they all know this information, but the velocity is king and it's effective. And that's what helps them get into college and get paid. So they're going to keep doing it anyway. So we can keep having that argument with them about injury risk, but they're going to keep saying, sure, doc, I don't care. I'm going to keep slinging it.
Unfortunately, it's not just the youth athletes; it's also their parents.
Yes,
totally.
They see it as well.
Well, the other thing too is you ask them if they play year round, and they go, "Oh no, I don't play year round. They only play during their season, but then they throw year round."
Yeah,
so
exactly.
Same thing.
Right.
So you are playing year round. Exactly. Yeah. So we talked about non-surgical treatment, and we kind of briefly touched upon indications for surgical treatment, but I want to talk a little bit more about that. So is there any presentation that would make you say, we're not going to do conservative treatment, we're going to go right to surgery, and does timing of surgery matter? If you're thinking about surgery, is it safe to let them get through the season, or do you think it impacts their outcome? Arthrex, a global leader in minimally invasive surgery, creating over 1,000 new products every year, thanks you for listening to this podcast. To learn more about how surgeons and Arthrex are treating the world's most elite athletes, please visit @ArthrexAthlete on Instagram.
Arthrex Athlete brings you the most inspiring stories of collegiate, professional, and Olympic athletes who have returned from their injuries thanks to their own determination, as well as talented surgeons, physical therapists, trainers, and advanced Arthrex innovations.
From college players to elite pros, Arthrex and their healthcare professionals are helping athletes recover and get back to doing what they love.
Again, that's @ArthrexAthlete on Instagram. Like, follow, and share these incredible comeback stories. You can also learn how to share your own by contacting patientstories@arthrex.com.
So again, I think it depends upon the status of that ligament. If you have a young athlete that has a distal full thickness tear, much more likely to recommend doing a surgery. And I think that's an excellent candidate for a repair in that setting. On the same note, if you have someone that's a bit more mature that has a ligament that's torn right in the middle, that also is someone that is very rare for me to recommend conservative care.
Absolutely.
Yeah, I would agree. I think the complete tear in somebody who wants to continue pitching, especially, almost always is going to end up with surgery. So in my opinion, there's not a huge downside from my perspective on waiting. I think that ligament can still be fixed if we wait a little bit, but it's a huge detriment to the athlete, particularly the high school athlete. So if they get injured in season and we spend 3 or 4 months of non-operative treatment and then decide 4 or 5 months later they fail, then we do surgery. Now they've missed 2 years and baseball is not like golf or tennis. It doesn't matter how good you are. You only have so many years you can play it. And so, stealing 2 seasons from these kids, it can be really challenging. So that's really the thing we want to avoid at all cost.
Yeah, I think especially with that youth athlete, that's their social, that's their, essentially like their mental health.
Their identity.
Their identity.
Yes.
And in the pros, too, looking at their career timeline, I think is important, and where we are in the season as far as if you're going to wait or not. But some of them still, need that 6 weeks to prove to themselves that they can't keep going.
Yes.
Yeah, no, I think that's a fair point.
Yeah.
So, there's options out there. There's the UCL repair. You can recon with an augment. You can just recon alone. Chris, can you talk about, shifts towards UCL repairs, or, where do you fall on this spectrum, and, where are your thoughts these days?
Yeah, landscape keeps changing. So, the UCL repair with internal brace augmentation has really taken off, has been really popular. It seems to be an excellent option, particularly for the younger athlete, the high school athlete, the college athlete. They have a little higher potential for healing anyway. They do very well. 90% or more returning to sport, and the return to play time is faster, 6 to 9 months, so which is wonderful compared to traditional reconstruction, which is usually over a year. I think what we're seeing, the concern with that, though, is that it may not work as well for the incredibly high-demand pitcher. So the major league or professional pitcher that's throwing at a high velocity, who's a little bit older as well, those may not last quite as long. And we're starting to get some data from MLB that's showing that there's a high rate of success, but when a repair does fail, it tends to fail much faster compared to other opportunities. So this surgical decision really has a trade-off that you have to weigh.
Yeah, Mike?
Yeah, I mean, I think you need to think of the UCL as a check rein. And, no matter what you do, there is still a chance that it's going to re-tear down the road in 5 or 10 years. And so I think that if you can do something that will preserve real estate, in the right setting that has a low likelihood of failing, then that's what you should do. So I think that in the younger athletes, if they have a fairly healthy looking ligament with either a proximal or distal tear, then I think that a repair is very reasonable to do. You still have a very easy way to do a revision recon. If you have a recon and someone, required the Tommy John surgery, we put a graft in there, some of those actually too you want to preparing because you're missing out on some real estate. So it really all depends upon the individual circumstance of the athlete and the status of their elbow and the status of their ligament.
Absolutely.
Now, you mentioned preserving real estate. So can you talk a little bit about your repair technique? How are you doing the repair? Are you always adding an internal brace? What does that look like?
That's how I've done it. I typically will use it, anchor proximally and distally. Depending upon where the tear is, I will use that anchor to repair that part down. I'll reef the ligament back together and then use the internal brace. The one thing that I have been seeing since I've been doing this, over the last, say, 5 years, I guess, is a little bit of a stress reaction at some of the anchors, which can be a source of pain. So it's something that I counsel the athlete on. I don't think it's a failure. It's just something that we have to work through as they get to that higher velocity throwing in that 9-month mark.
Mm-hmm. Yeah, but I think to your point, if they know it, that's the world of difference of just knowing that this might happen, and it doesn't necessarily mean, oh no, this is a complete failure.
Yeah.
And I think too, in addition to that, one of the big problems that we're facing right now is that when an athlete, a pitcher, has surgery for this, and they come out for 6 months, a year, or whatever, when they come back to baseball, that game has changed. The average fastball velocity is higher now than it was when they initially got injured. So they're coming back to a game that is requiring even more than what it was when they got injured. So it's really challenging. It's a huge
new
fight. It's like an
level.
arms race. It's us against the velocity. And part of what we're doing, we're adding internal braces, we're adding anchors, and we're getting smart about how to make these biomechanically stronger. But I think the next frontier is that we also have to respect the biology. And you mentioned that earlier too. So we want to respect the native ligament, repair it every time. We want, if we're adding a graft, add a graft in a way that we disrupt the native biology minimally. So minimal bone removal, don't disrupt the vascularity. Try to make it biologically friendly so that it will actually heal, and I think that will allow them to return to play faster. So that's sort of what we're working on now as we're moving more towards doing reconstructions with internal braces. We're saying, okay, how can we make this thing as biologically active as possible, as well as biomechanically strong? So we're trying to marry the both of those, and there's a few different ways we're doing that now. Some data's coming out that's encouraging, but we're still up against an enemy here that's growing faster than we are.
Yeah, so Chris, speak to that, like as far as like tips and tricks for the OR. How do you do that?
Yeah, so a couple things I would say too. So whatever your technique is, if you're doing a repair or reconstruction or an augmented reconstruction with internal brace, a few general principles for me: always repair the native ligament. So I always do, no matter how terrible it looks, no matter where it's hurt, where it's injured, even if it's multifocal. So I always repair the native ligament. And then I generally add a graft on top of that as well. And when adding your graft, you want to make sure that you get it as anatomic as possible. We do know that a common problem is that people are putting their sockets or their tunnels in the wrong place. The native ulnar collateral ligament is not an isometric structure. So if you get your anatomy off, you've taken something that was not isometric to start with and made it even less isometric, which is going to be a problem for that athlete. So really make sure that you get all of your tunnels and sockets, everything in the right location. Remove as little bone as possible, disrupt as little muscle, tendon, and vascularity as possible as well. And then also I do think we're seeing more and more internal braces being added even to our reconstructions. So we just looked back, and in 2023, over 1/3 of all the UCL surgeries in professional baseball pitchers were an augmented reconstruction. And that graft is going up rapidly. So I think pretty quickly we're going to see that's probably already over 50%, and it's going to become the majority. The most common surgery for this is probably going to be augmented reconstruction with this graft plus internal brace.
Yeah, that makes sense. So you touched a little bit upon your technique for reconstruction. There's typically docking, right? Figure of 8, and now there's a double cortical button technique that's been described. Can you talk us through the different techniques, and what do you prefer when you're doing a reconstruction?
Well, I think that when I learned this surgery, what was daunting was tunnel drilling. And so Joachim and Jobe used to just freehand everything, and all of a sudden, 20 minutes later, the whole surgery's done. I think that with the Arthrex guide system, it makes things very easy. And so as long as you know where your nerve is, and trying to protect the biology, I like to do a flexor tendon split. I think that as long as you can really localize your anatomy and put the tunnels in the right position, then it could be a very simple surgery, actually. With regard to the buttons, I will use the buttons more in revision settings. So if you're dealing with issues where there's prior tunnels are in the wrong position, you can correct that by putting your tunnel in the right position. But if you have an issue with the back wall, then utilizing a button for that. So that's usually when I will do that.
That makes sense.
Yeah, a line I always use with the fellows, I tell them using the guides is less fun, but definitely more precise. And yeah, it's fun to be an artisan or a craftsman in there just kind of, eyeballing everything, but it is absolutely less precise. So, and precision is the key here, far more important than fun. So you need to use the guides, you need to be precise. And I think the docking and modified Jobe are still the workhorses out there for most people. Interesting though, those were described over 20 years ago, haven't changed much, which is kind of interesting. For me, I've actually I use the anatomic technique, and that's what I've been doing exclusively for the last 5 years or so, just trying to preserve as much bone as possible and improve the vascularity and increasing tendon to bone contact.
Yeah.
And I'll use a docking technique nowadays as well, but I try to keep as much collagen in there. So not just having two limbs go into the tunnel, have a limb come back. I also think with augmentation, it's always different. Like everyone does it a different way, depending upon where in the country that they're getting this done. I think that you can do a very nice internal brace without even using anchors. If you have a healthy part of ligament, that you can then bring those sutures up through your drill tunnels and tie them over the back, even over a button.
I agree. I do think there's a trade-off. And that's a perfect point, too. So if you add the internal brace, you're adding biomechanical strength. But if you also add a bunch of extra drill holes and anchors and other things, now you're stealing from the biology.
Right.
So you're kind of robbing Peter to pay Paul there. So I would encourage people who are looking at incorporating an internal brace into their configuration, try to do so in a way that you don't have to compromise the biology to do that. And there are several techniques where you can do it. You can run it with your graft without having to put any extra holes in the bone anywhere.
Yeah. Mike, what are you telling your patients or their parents about UCL reconstruction? What can they expect as far as their return to performance?
Well, particularly when you're dealing with the youth athletes and the parents, I think I try to be very conservative. I try to put an expectation this is going to be 16 to 18 months before they're back. It's never going to be, and they'll never listen to me all the way. But if I can put that there and I can really push that agenda, I think that's important because this is a ligamentization process, just like all the other surgeries we do. ACL surgery, it takes a long time because of that biology. You're taking a tendon and turning that into a ligament, and that just takes time. No matter how much physical therapy they do, we got to respect that time course.
Yeah, absolutely.
And there are two tips that I always give all my patients. Oftentimes they say, oh, well, I know so-and-so who threw harder after they had Tommy John. Right? So we always have to
Yeah,
fight
we
that.
were going to ask you that.
But I'm going to be better.
I use that. I leverage that actually with my patients, and I say, listen, you're right, they did, but it had nothing to do with the surgery. It's because of the rehab. I said, so if you want to be that individual, it's going to be up to you to do the rehab and take care of it. So I use that to say, now's a chance for you to do this, and this rehab is going to be an educational process for you. You're not just recovering from this injury, but you're going to learn how to take care of your arm the right way, and then you need to do that for the rest of your career. And I also say this is a rare opportunity that you have to take care of the rest of your body because now you're not going to be playing 6-7 games a week.
Yeah.
You can actually get the rest of your body in shape. So work on your core and your balance and your proprioception and your mobility and everything else. So really use this time to get yourself in good shape. So I try to take that expectation and flip it back on them and say, maybe you will, but it's going to be up to you.
Exactly. It's on you.
Yeah. No, I like that.
So another thing we want to talk about is what to do with the ulnar nerve. So in terms of reconstruction, do you leave it alone? Do you transpose it? So Chris, how do you decide what to do with the ulnar nerve at the time of a reconstruction or repair?
Yeah, and I think the data is pretty clear on this. There's a few systematic reviews out there now, and essentially, if you transpose the nerve routinely, those patients, everybody does well overall, but those patients tend to have more ulnar nerve issues early. Okay. If you leave the ulnar nerve alone, there's a higher likelihood that they might need a subsequent ulnar nerve transposition later in their career. So pick and choose. For me personally, I would rather not introduce a new problem. I would rather take care of a new problem if it comes up in a few years. So if they don't have ulnar nerve symptoms, I leave the ulnar nerve alone. I find it in surgery. I don't dissect it out, but I palpate it repetitively, so I know where it is the whole time. But I don't transpose it unless they're actively having symptoms. And I would also say, too, in the thrower, I never do a in situ decompression. So if I'm decompressing it, I am transposing it. Otherwise, they're going to develop instability and have problems.
Yeah, I feel the exact same way. If they have prior symptoms or they have a really super mobile nerve that I'm worried about, then I will do it. But probably only, 5 to 10% of my cases will get that.
Yeah. I know, it reminds me of like posterior lateral corner. You're like, it's right there. It's right there. It's
Exactly.
right there.
Yes,
Just keep checking it.
Yes.
So we're going to finish up just talking about rehab, return to sport. So, Chris, how are you, managing their post-op protocol? Let's talk about repair.
So I actually have, I'm very simple. So I have two protocols.
Yeah. Okay.
I have a standard protocol and an accelerated protocol.
Okay.
So I actually offer, if it's a standard reconstruction without an internal brace or revision, they do the standard protocol. That's typically a 12-month timeline for pitchers.
Okay.
I have an accelerated protocol that I use for repairs with the internal brace or reconstruction with the internal brace.
Okay.
So the augmented reconstructions get the same one. And they end up going through a process. They're in a brace for a few weeks, working on range of motion for up to 6 weeks. Strengthening starts at 6 weeks, and that usually goes through 12 weeks. Then we initiate a throwing program with some plyo balls for a few weeks. As long as they progress to that, then we start throwing. One of the things I think we need to improve, and we're working on this, we've rewritten our protocol so that we have different exit points for different players. Because we tend to think of the throwers, we put them all in one bucket. But the needs of a starting pitcher are very different from a reliever, which is very different from a second baseman or an outfielder or a catcher. So you have to be thoughtful in that. And obviously a second baseman or first baseman doesn't need the same amount of throwing that a starting pitcher is going to need. So ours is sort of tailored to that to try to get them ready for whatever it is they're going to be doing on the field. And in the rehab protocol, we try to get them to a point where what they see in rehab is going to be slightly more stressful than what they're going to go back to in the game. So that's the general principle that we use.
Yeah, very similar for myself. I think that the first first couple of weeks is in a splint, and they transition to a brace, try to get full range of motion by around 6 weeks. Then it's all about isometric strengthening, progressing to regular strengthening, with the idea that they have a muscular envelope that can protect the elbow as they start getting into their throwing program. So a throwing program usually will start around the 4 to 6 month mark. If they're a position player, as far as batting, it usually starts around that 4 month mark as well.
Yeah, what do you think about the technique? Like, how much does that, as far as their throwing technique, do you find that that's changed for them? Like, do they have, just problems with that, returning to their same technique?
I'm sure that they do. That's one of the things I think is very unfortunate in that I never see them. I see them in the office, but I don't really know exactly what they're doing. And they could be throwing with a coach, they could be throwing with their dad. It's all over the map with regard to what they do. But typically, the progression is doing some light toss, going to long toss, starting to throw from the flat ground, and then going to a mound.
And we actually studied this in professional pitchers. We surveyed them after they got back, and about 40% of them said they had to change their mechanics in some way in order to get back. Yeah. So there is a large portion of them that do that. Fortunately, at that level, they have a lot of coaching and people that can watch over. One other thing, you mentioned how rehab varies based on technique. One of the things I will say is that if you use an internal brace, either in a repair or in a reconstruction, they can be stiff. Okay. And so that brace is really helpful. It's serving its job, but it can make them stiff, especially in flexion. So oftentimes, if you're using that, keep an eye on that. And if they're looking like they're going to be stiff, get them going on their flexion a little bit earlier.
Yeah. Now, in terms of return to play, I know we talk a lot about ACL on our podcast, and we talk about how there's all this return to play criteria and tests you can put people through and surveys we have them do and fear of re-injury and all that. Is there something similar for UCL to determine safe clearance for a sport? Is there anything you're having PT do or any surveys you're doing with the patient to make sure that they're prepared to get back in?
For me, it really is more their throwing progression. Like if they're able to do their bullpens and they're throwing at the velocity they want to throw at, they're not having a tremendous amount of soreness afterwards and not having to recover for a prolonged period of time. Then that's my judgment call.
Yeah,
I agree, and that's nice too because they're not going to get there if they're having the other issues. So that's sort of a way of kind of weeding everything out.
Yeah,
got it.
Yeah, great point.
And then the last thing we want to talk about is prevention. So, a big focus, a lot of times you come to these meetings, we just want to talk about surgery and surgical technique and how that's evolved, right? But if we can save these kids from undergoing a surgery in the first place, we've really done a win. So in terms of prevention, what are you talking to your athletes about? What's the most important thing to try to minimize the risk of UCL injury?
Yeah, so I go back to those, 3 buckets of risk factors. So just to repeat, for the younger athlete, it's poor mechanics, throwing too much or throwing too hard. It's hard. Younger athletes usually have terrible mechanics, so I do encourage them to work with somebody who can help them with that, but they don't always have access to that. The lowest hanging fruit is the throwing volume, so how much they're throwing. So whatever you can do to try to get them out of that. So either I recommend that they take 2 months off of throwing completely at some point during the year if they can, or at least have a season where they're not pitching. Go play first base for a season. So with the youth athletes, it's usually the volume issue I feel like is the most high yield discussion topic that you can have. So that's sort of the thing that I go after first for the young athletes. For the higher end athletes, the elite athletes and the professional athletes, it's really challenging.
Yeah.
Their mechanics are already good. We can't really change the volume, and they're going to keep throwing hard. So in that group, it's really just talking about how can we optimize all of the other things. Talking about your nutrition, your sleep, and your mobility,
recovery.
and your core strength, and your recovery, and supplementations. Are you filling yourself up with toxins and drugs and alcohol, other things you shouldn't be doing. So having some of those conversations, I think, can be helpful. Nicotine is probably, a big component of it. And now we're seeing that THC in cannabis affects blood flow. So sometimes even having some of those conversations, hard to make headway on those topics, but those might be things to consider.
Got it.
Yeah, I completely agree. I think that the volume issue is the main thing with regard to the younger athlete. But in the collegiate and pros, it's really hard. You typically can't even have that conversation until after it's torn.
Yeah, I bet.
I believe it.
Yeah.
It's too late. Well, thank you so much for taking time out of your very busy schedule to talk about this. This was really informative, and we thank you.
Yeah, super helpful.
Thanks for
Honor
having
to
us.
have you both on. Thank you so much.
Appreciate it.
Yeah.
Thank you. This was great.
Thank you for listening to this episode of the Sports Talks podcast. We hope you enjoyed the discussion as much as we did. Make sure to subscribe on Apple Podcasts, Spotify, Amazon Music, and on YouTube to stay up to date on all things sports medicine. If you like what you hear, please consider leaving us a review or comment. You can also reach us by email at thesportstalkpod@gmail.com or find us on Instagram at thesportstalkspod. We love your feedback.